ever stop and think about what's really pulling the strings behind everything your body does?
Mm.
Like hunger, sleep, growth, even reproduction. Feels like there must be some kind of master control center, right?
Absolutely. Hidden conductor.
Exactly. Well, today we're diving deep into that very system. It's the body's ultimate command center, the hypothalamic-pituitary axis.
The HPA. Yeah. Crucial stuff.
Right. And our mission today isn't just, reading off a list. We want to really unpack how the hypothalamus and pituitary gland work together.
And what happens when they don't?
Exactly. When things go off key, we'll pull out the key insights, the must-know terms. Think of it like prepping for med school orals, maybe.
Yeah.
But hopefully a bit more relaxed.
Definitely less stressful. And understanding this axis is so important because when it malfunctions, you see this huge range of symptoms.
Stuff that seems unrelated.
Totally unrelated sometimes. It really tests your critical thinking, trying to connect those dots back to this one central system.
Okay, let's start at the top then. The conductor itself, the hypothalamus. Tiny part of the brain, but sounds like it does. Well, almost everything.
It really is the orchestrator. I mean, fundamentally, it controlled your body temperature, appetite, thirst, sexual behavior, your sleep cycle, the whole circadian rhythm thing, and the autonomic nervous system.
Wow. So all the absolute core functions for survival and daily life.
Pretty much. Your body's basic operating system.
But how does it do that? It's not just getting signals, it's sending them to, right?
Right. And that's its real power. It makes hormones, specifically releasing hormones, which are also called liberins, and inhibiting hormones, or statins.
Okay.
These are like specific instructions sent directly to the anterior pituitary, the adenohypophysis. Tells it exactly what to release and when.
So it's manufacturing the order.
Exactly. And don't forget its other connection. It also makes ADH, antidiuretic hormone, and oxytocin.
Oh, right. In those specific nuclei, the supraoptic and paraventricular. Precisely. Those hormones then travel down nerve pathways to be stored and released from the posterior pituitary. So the posterior pituitary is like the release dock, but the hypothalamus is the factory and the boss.
Got it. Factory and boss. So if it's that central, that vital, what makes it malfunction? What can go wrong with the conductor?
Well, unfortunately, quite a few things. Tumors are a big one, obviously. Physical trauma, complications from surgery, ischemia, lack of blood flow, also inflammation, hemorrhage, side effects from radiotherapy to the head, and even things like severe stress can impact hypothalamic function.
And if the command center is hit, what's the immediate fallout? The first domino?
The immediate result is usually decreased production of those releasing and inhibiting hormones we talked about.
So the signals stop or slow down.
Exactly, which means the anterior pituitary doesn't get stimulated properly, and that leads directly to hypopituitarism. The pituitary's output drops because its orders aren't coming through. And of course, damage to those specific nuclei means less ADH or oxytocin gets made and sent to the posterior pituitary for release.
Okay, so let's trace that out. If those releasing hormones aren't getting through, what specific hormones downstream are affected? What does that look like in the body?
It's a cascade, like you said, a real domino effect.
Yeah.
So if you lose CRH, that's corticotropin-releasing hormone, then the pituitary makes less ACTH, which means the adrenal glands make less cortisol. That's adrenal insufficiency, potentially very dangerous.
Yeah, life-threatening.
Definitely.
Yeah.
Then less TRH means less TSH, which leads to hypothyroidism.
Makes sense.
Less GnRH means less LH and FSH, causing hypogonadism. Problems with fertility, libido, that sort of thing. If you lose GHRH, you get less GH, growth hormone. In kids, that's dwarfism.
Right.
And less PRH means less prolactin, so women might experience failure of lactation.
It really affects almost every major system, doesn't it? So clinically, how does this manifest? Does it look different in kids versus adults?
Oh, absolutely. Very different presentations. In children, the big signs are growth retardation and delayed puberty. The hormones needed just aren't there.
Okay.
In adults, it's often things like amenorrhea, loss of periods, or infertility in women. For men, impotence, loss of libido, plus more general symptoms like just profound fatigue, maybe hypotension, low blood pressure.
So you could have someone presenting with fatigue and infertility, and the root cause is way back up in the hypothalamus.
Exactly. Seemingly unrelated things, all pointing back to that central control failure. It's a classic example of that domino effect.
Okay, let's zoom in on one specific consequence. You mentioned ADH. That controls water balance, right? And when that goes wrong, sounds dramatic.
It can be extremely dramatic. Take central diabetes insipidus, or CDI. This happens when those hypothalamic nuclei supraoptic and paraventricular are damaged or destroyed.
So not enough ADH gets made.
Exactly. And without ADH, your kidneys just can't reabsorb water properly. They can't concentrate urine, leading to massive polyuria. We're talking huge volumes of urine, sometimes more than 20 liters a day.
20 liters? Wow.
Yeah, which naturally causes intense polydipsia, constant, excessive thirst. And if they can't keep up with fluid intake, severe dehydration.
How do you pin down that diagnosis? Because excessive thirst and urination could be other things too, like diabetes mellitus.
Good point. Key clues are very dilute urine, low urine osmolality, usually under 200 mL/kg. Then there's the water deprivation test.
How does that work?
You restrict water intake under supervision. Someone with CDI won't be able to concentrate their urine. It stays dilute because they lack ADH. But the clincher is giving them ADH therapy, like desmopressin.
And if it works?
If their urine then concentrates, that confirms it's central DI. The problem is the lack of ADH production. This differentiates it from nephrogenic DI, where the kidneys just don't respond to ADH even if it's there.
Fascinating. So the brain's control is that precise?
Incredibly precise. A tiny failure point leads to massive fluid imbalance.
All right, so that's too little ADH. What about the opposite? Can you have too much?
Absolutely. And that's equally dangerous. That's the syndrome of inappropriate ADH secretion, or SIADH.
Inappropriate secretion, meaning the body's making ADH when it shouldn't.
Exactly. Often this is paraneoplastic.
Meaning it's linked to a cancer somewhere else.
Correct. The classic example is small cell lung carcinoma. The tumor itself actually produces ADH.
Wow. So what does all that extra ADH do?
It causes the body to retain too much water. This dilutes the blood, leading to dilutional hyponatremia, dangerously low sodium levels.
And low sodium is bad news for the brain, right?
Very bad news. Water moves into brain cells, causing swelling, brain edema. Symptoms range from headache and nausea to confusion, seizures, and potentially coma.
That sounds incredibly serious.
It is. And there's a tricky detail. The excess fluid volume actually suppresses aldosterone release.
Which normally helps retain sodium.
Right. So paradoxically, you end up losing more sodium in the urine, making the hyponatremia even worse. It's a dangerous spiral.
Okay, we've spent a lot of time on the too little side, hypothalamic hypofunction. Does the hypothalamus ever become overactive? Hyperfunction.
It can, yes. Though maybe it's less common to see it as a broad syndrome. The classic example of hypothalamic hyperfunction is precocious puberty. Pubertas precox.
Meaning puberty starts way too early.
Exactly. This is caused by increased production of GnRH from the hypothalamus, which kicks off the whole puberty cascade prematurely.
So a young child starts developing adult characteristics. How do you sort that out?
Well, you have to differentiate it carefully. There's true precocious puberty, where the signal genuinely originates in the hypothalamus. The whole axis is just switched on too early.
Okay.
But then there's pseudo-precocious puberty. This is where you see the signs of puberty, but it's caused by excess sex steroids coming from somewhere else, like an adrenal tumor or a gonadal tumor. In pseudo-precocious puberty, the hypothalamic GnRH is not elevated, it's often suppressed.
So the source is different. Peripheral, not central.
Exactly. Pinpointing the source, central hypothalamic versus peripheral gland, is absolutely critical for diagnosis and the right treatment.
Right. Okay, so if the hypothalamus is the conductor, sending out the signals, the pituitary gland is like the first violin, taking the cues and producing the actual hormones that go up to the body.
That's a great way to think about it. The pituitary is the direct interface, executing the commands.
So let's shift focus there. What happens when the pituitary itself is the problem? Starting with too much activity, hyperpituitarism.
Right. Increased pituitary hormone levels. And the number one cause, by far, is a pituitary adenoma.
A tumor on the pituitary.
Yes, usually benign tumors. We split them into functioning adenomas, which actively overproduce one or more hormones, and non-functioning adenomas. These don't make excess hormones themselves, but they can grow large enough to compress the healthy pituitary tissue, causing hypopituitarism or press on nearby structures.
Okay, so let's talk about the functioning ones. What hormones are most commonly overproduced, and what does that cause?
The most common is definitely excess prolactin, PRL. In women, that classically causes amenorrhea and galactorrhea, making milk when not breastfeeding.
Right.
In men, it can lead to gynecomastia, breast tissue development, loss of libido, infertility.
Okay. What else?
Excess growth hormone, GH, is another big one. If it happens in kids before their bones fuse, you get gigantism, just extraordinary height.
Like literal giants.
Pretty much. In adults, after the growth plates close, it causes acromegaly.
That's the one with the enlarged hands, feet, facial features.
Exactly. Coarsening of features, jaw growth, plus organomegaly, enlargement of internal organs. And this excess GH leads to high levels of IGF-1, which increases the risk for cancers, diabetes, hypertension.
Serious long-term risks. What about ACTH?
Excess ACTH from a pituitary adenoma causes Cushing's disease. Remember, disease means pituitary source. Cushing's syndrome is broader.
Got it. And the symptoms?
Very characteristic. Central obesity, weight gain around the trunk, thin limbs, a moon face, purplish striae, stretch marks, hypertension, weak bones, osteoporosis, diabetes, and being prone to infections due to immunosuppression.
Quite a list.
It is. We can also see excess TSH, FSH, or LH, though that's rarer, often less obvious clinically, and some tumors are plurihormonal, making several hormones at once, which really complicates the picture.
Aside from the hormone effects, these adenomas are growing inside the skull. Do they cause problems just by taking up space?
Absolutely crucial point, especially the larger ones, the macroadenomas. They can press upwards on the optic chiasm.
Where the optic nerves cross over.
Exactly. And that pressure causes very specific type of vision loss called bitemporal hemianopia, loss of the outer peripheral vision in both eyes. Sometimes that visual symptom is actually the first thing that brings someone to the doctor.
Tunnel vision, essentially.
Kinda, yeah. Loss of the sides.
Okay, that covers the too much from the pituitary. What about too little? Hypopituitarism caused by pituitary problems.
Right. Decreased pituitary hormones. Causes are varied. Pituitary infarction, tissue death from lack of blood supply. Those non-functioning tumors squashing the gland. Radiation therapy to the head. Surgery complications.
And isn't there a specific, quite dramatic syndrome linked to childbirth?
Yes, very important. Sheehan's syndrome. This is postpartum necrosis of the pituitary.
Necrosis meaning tissue death.
Yes. It happens after severe blood loss during or after delivery. The pituitary actually enlarges significantly during pregnancy, physiological hyperplasia.
Making it more vulnerable.
Exactly. More vulnerable to ischemia if there's a sudden drop in blood pressure or volume, like with a major hemorrhage. The enlarged gland essentially infarcts.
And the classic signs.
The new mother fails to lactate, no milk production, and then experiences menorrhea. Her periods don't return. That points strongly towards Sheehan's.
And just like with the hypothalamus causing hypopituitarism, the specific symptoms depend on which pituitary hormones are lost, right?
Precisely. It mirrors the hypothalamic list, but the failure point is the pituitary itself. So low GH means dwarfism in kids. Low FSH-LH causes hypogonadism, infertility, loss of secondary sexual characteristics.
Okay.
Low TSH leads to hypothyroidism. Low ACTH is critical, causing adrenal insufficiency, which can be life-threatening.
Definitely need cortisol.
Absolutely. And even low MSH, melanocyte-stimulating hormone, can contribute to pale skin and some hair loss. So the pituitary is this powerhouse factory. And problems there, tumors causing too much or damage causing too little, have massive ripple effects. Sometimes vision changes are the first clue.
What an amazing, complex system. We've gone from the brain's master conductor, the hypothalamus, down to its first violin, the pituitary, and seen how tightly linked they are.
Absolutely.
Controlling everything from our basic drives to growth, metabolism, stress response. It really is the hypothalamic-pituitary axis running the show behind the scenes. Understanding how it works and how it breaks, it just seems fundamental.
It really is.
Yeah.
And it makes you think. Considering all those diverse symptoms we talked about, thirst, growth issues, infertility, fatigue, vision changes, mood, how can understanding this central axis change how we approach patients with complex, maybe confusing presentations? What does the delicate balance of this system tell us about health itself? And how often might the answer to a medical puzzle lie hidden within the HPA?
That is definitely something to ponder. A fantastic point to end on. Thank you so much for walking us through that.
My pleasure.
And thank you for joining us on this deep dive. Hopefully you feel a bit more clued in to the incredible command center running inside you. Until next time, keep exploring, keep learning, stay curious.